Ms. Hands.
Good morning, my lady. If I may call Claire Sutton, please.
Okay, repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Okay, thank you.
Sutton, thank you very much for coming to join us and to help us.
Good morning, Ms Sutton. You are here today to provide evidence on behalf of the Royal College of Nursing, or RCN, if I may, and you have provided a statement, and that is at INQ 308587657. I understand that your job title may have changed since the statement was signed. So can you please tell us what your current job title is?
My current job title is Head of Independent Health and Social Care.
Thank you. And how long have you held that role for?
The job title changed on the 1st of January of this year. It's exactly the same role. It was just to bring me in line with colleagues.
Ms Sutton, you've got a very quiet voice. If I may ask you to just speak a little bit louder and perhaps into the microphone. Thank you. And is that a role that you held during the pandemic?
No. So I joined the Royal College of Nursing in August 2022.
What was your role during the pandemic?
I was a digital transformation lead at the National Care Forum.
And is it also right that you are a registered nurse with experience in nursing homes as well?
I am.
The inquiry has heard about the role of the RCN in other modules. Today, of course, we're focused on the role of the RCN in adult social care. So if I may start with the RCN's role in central government planning around adult social care prior to at the start of the pandemic.
Yeah, so the RCN has always engaged with government and with other agencies in order to support the voice of nursing and provide the voice of nursing across health and social care. And that was prior to the pandemic and during and since.
And was that the position in each nation?
Yes.
You have explained in your statement some of the extra support, I suppose, that the RCN provided to your members during the pandemic and to the general public as well. And that includes the RCN call centre and the RCN care home network. Could you briefly explain each service and the benefits that it brought to the sector during the pandemic?
So the RCN call centre, otherwise known as RCN Direct or RCND, is the primary contact route for members who need to contact the RCN for advice or resources. We are, of course, both a professional body and a trade union, so it enables members to be able to contact us for questions and queries they may have on both aspects of that. The Care Home Nurses Network that was set up during the pandemic is a Facebook group that was set up to support peer-to-peer interactions and sharing of best practice and challenges that they were encountering throughout the pandemic.
And when was that set up?
I don't know the exact date, but I think it is in my witness statement.
And was that was the feedback from that it was helpful during the pandemic?
Yes, I think because certainly working in social care, it can be quite isolating for nurses. In a lot of social care settings, both care homes and possibly even more so in home care settings, you may be the only nurse on duty. So having that route of being able to contact and speak with peers was really helpful, and members reported that. And indeed, the page is still active and still used regularly by members now.
Thank you. The inquiry has heard about staff shortages and retention issues in the sector going into the pandemic, and you have certainly addressed that at some length in your statement. One of the mechanisms introduced to try and mitigate the impact of those shortages were powers for the Nursing and Midwifery Council to establish a COVID-19 temporary register. And that applied to both health and social care sectors. Just to clarify, that did include those working in adult social care as well, didn't it?
It did. So people who joined the COVID temporary register as a registered nurse, it wasn't specifically just for NHS nursing roles. It was for nursing roles across health and social care.
And the creation of that emergency register, was that something that the RCN supported?
Absolutely, with caveats that nurses should be supported in exactly the same way that we would expect nurses that were on the full register to be supported with access to training and employment pay terms and conditions.
Yes, and what were the RCN's experiences around support, supervision and implementation of the register?
By and large, it was a positive thing.
And was that the case across the whole of the UK, or were there issues in some of the nations?
I'm not particularly aware of specific issues in any of the devolved nations.
Okay. I think you've said in your statement that mobilisation in Scotland was quite slow and that there was poor implementation in Wales. Are you able to help us perhaps with some of the reasons for that?
I think in terms of actually placing nurses in roles, it wasn't always particularly straightforward. More so in social care as well, really. And I think a lot of that is because there isn't that centralised recruitment in social care. So social care provision is tens of thousands of different organisations, and each of those organisations employs their workforce themselves. So the implementation of ensuring the employment checks and getting people onboarded and commencing in work in social care was a little bit slower, I think, than the NHS. Does that help?
Yes, thank you. Was there engagement with the RCN about implementation of how that could be improved?
Engagement with the RCN on this and a number of other things was not necessarily consistent. So we found that different governments, particularly early on in the pandemic, and of course this was quite early on the temporary register, was not always easy to achieve. Certainly in Wales in particular, the engagement with Welsh government wasn't always as rapid to get started. Scotland, a little bit better. There was more kind of collaborative working, and the RCN were invited to contribute to much more discussions in Scotland. Again, Northern Ireland, there was good communication and good consultation of the RCN in decision making.
Were you able to discern any differences about the pre-pandemic relationships in those different nations, which perhaps informed the strength of those relationships and that engagement during the pandemic?
I think the early stages of the pandemic were probably quite similar to what the relationships were at that time. The RCN always seeks to be involved and provide that voice of nursing where decision making and policy making is being undertaken. It's not always necessarily a popular decision to have the RCN there. As I mentioned, obviously we are a trade union and a professional body as well. So it's not always, we're not always immediately invited to be a part of any consultation, but we will always seek to be a part of it.
Just finishing on the topic of the register and the temporary emergency register, you've said in your statement that as of July 2020, there were approximately 14,000 people on the UK-wide register. Do we know the breakdown between healthcare and social care within that figure?
No. So the NMC register, the normal full register doesn't break down between nurses that work in different areas, particularly. So I don't think anybody would be able to provide you with the details of how that 14,000 was broken down.
So are we able to say whether it was an effective mechanism for increasing capacity of the adult social care workforce during the pandemic?
I don't think we could be that specific, really.
Thank you. Your statement also includes some positive accounts from staff of resilience and supporting one another, embracing opportunities for change. But there were also problems for providers and staff caused by the staff shortages. And if we can have on screen, please, INQ 30587-657, page 113. This is taken from your statement. And two of the responses to the surveys that the RCN carried out during the pandemic. So at the, paragraph 377A, we can see a nursing, somebody responding said, I work in a nursing home that cares for 81 residents. It's divided into 4 units. One of the units was short-staffed, and on top of that, one of the care assistants working there became acutely ill and needed to go home, leaving the unit very short. And then at paragraph B, somebody else said that they were struggling with staffing levels to provide safe, effective care to residents, but was overruled by senior management directors and made to work short-staffed. Were those type of concerns widespread in your experience?
Yes, they are themes that are common across social care, both prior to, during and since the pandemic.
In terms of retention rates, the RCN survey that was undertaken in 2021 showed that 52% of those working in care homes were thinking about or actively planning to leave their job. Did you hear whether the reasons for that were related to the pandemic?
I don't think we know the specific reasons, but it's certainly a very high figure of nurses that expressed that they were either considering or are actively looking to leave their current roles.
And in terms of if there were a future pandemic, how do you think we could improve support to ensure that there isn't such a negative impact on retention rates in future?
I think social care often feels like a second-class citizen, a poor relative, and there are so many reasons for that, and they are reasons that go widely beyond anything that could be, come as a recommendation from this. But I think if we were to have parity of esteem and equity of access to the same resources and the same testing and PPE and everything that the NHS have got, then that would definitely support social care to not feel that they were the poor relative, and would boost staff morale and hopefully go some way towards changing those perceptions around whether people would want to stay in their job and improve staff retention as a result.
I understand that, obviously, it makes perfect sense. But isn't the problem that you're then getting the state to step in and, for example, provide PPE for the employees of a private company?
So although the majority of social care is delivered by independent private companies, the majority of that care is funded by the state. So local authority funded social care, continuing healthcare and funded nursing care that's funded through the NHS. And I think that although there is lots of private companies, that are providing it, they're not all for profit. There are areas that are still being delivered directly by local authorities or through not-for-profit organisations commissioned by local authorities and NHS to deliver that care.
Thank you.
A slightly different topic, but still focused on the workforce, and that's around data collection. At paragraph 319 of your statement, you have referred to a meeting that took place between the RCN and the Association of Directors of Adult Social Care Services at the start of May 2020, where both organisations agreed that the recording and reporting of deaths of health and care workers were inadequate. Did any action or changes follow that meeting, to your knowledge?
Not to my knowledge.
And are you able to help us whether the recording and reporting of deaths of care workers did in fact improve during the pandemic?
The recording and reporting of the deaths of care workers throughout the pandemic is very difficult to do. In order for an occupational death to be recorded, it has to be clear that it is an occupational death, and the COVID virus was endemic in society. So, if a healthcare worker was to contract the virus and to unfortunately die as a result of it, the difficulty comes in ascertaining where that virus was contracted.
Do you think it is something that needs to and perhaps could be improved in a future pandemic?
I think it would need to be improved in a future pandemic. I think it's very important to be able to capture how the workforce are affected by any pandemic situation, and I think that there would need to be thought put in, and I'm sorry, I don't have the answer as to how it would be done, but I think there would need to be consideration as to how that could be better captured.
Thank you. Moving on then to a different topic, and that's IPC guidance and measures for the sector. You have included in your statement some of the concerns and experiences that the RCN and its members had, including some through the RCND, the call centre that you mentioned at the start. So if we could have on screen, please, INQ 30587-657, page 49, paragraph 173D to start with. Thank you. Again, so these were concerns that were raised by a member working in a care home in England at the very start of the pandemic in March. And they said that they work for a care home and there was nothing in place to protect us during this pandemic, no senior leadership in place, no PPE, no instruction on how to deal with this pandemic or what to do if one of our residents gets symptoms of COVID-19. And then paragraph F, thank you, another member said that they had been informed that there would be masks delivered to the nursing home, but staff are not to have them unless there is a concern of an outbreak within the home. And the member was unsure if they should be given beforehand to prevent an outbreak, as the past week patients have coughed and spat on me. And that was from a member working in a care home in Scotland, again in March 2020. So again, Ms Sutton, were those reflective of experiences that you heard from your members?
Yes.
I'd like to turn to look at some of the guidance in a little bit more detail, if I may. The first guidance issued by Public Health England for social or community care and residential settings on COVID-19 was on the 25th of February 2020. And that recommended that the best way to reduce any risk of infection for anyone is avoiding direct or close contact within 2 metres with any potentially infected person. Are you able to tell us how practical it was to implement that advice and to avoid close contact with a potentially infected person for nurses providing care in the adult social care sector?
Impossible. You can't provide care, direct care and support to individuals if you can't get within 2 metres of them. These are some of the most vulnerable people in society who have really high care needs. And in order to be able to provide that care to those people, you would need to be able to be in close proximity to them.
It also advised in that guidance on the 25th of February that face masks did not need to be worn unless an individual was infected and it had been advised by a healthcare worker. Are you able to help us as to whether there was sufficient access to tests at this time to know if the care worker or recipient of care was positive for COVID-19?
It was very difficult to access tests at that time. This was also around the time that there wasn't the understanding of asymptomatic transmission. So in order to be able to access a test, you had to be able to answer a series of questions that demonstrated you had particular symptoms in order to be able to get an appointment to go and get a test. To then go and get that test, you would have to go to a test site that in the main you had to drive to. Many people working in the social care sector don't have access to a car. They're not able to drive to a test site to be able to get it. The distance to travel to some of these test sites was lengthy. I can recall myself needing to access a test around this time, and I live in Southport and was sent. They wanted to offer me an appointment at a test site in Blackpool, which as the crow flies is about 7 miles, but it's well over an hour's drive. So there were a number of different barriers in place that made it extremely difficult for people to be able to access testing at this time.
Finally, the guidance said this, which you've included in your statement as well. It remains very unlikely that people receiving care in a care home or in the community will become infected. So if I may, what were the RCN's views on this statement being included in the guidance at this time?
I don't know how they could possibly have said that. How somebody living in a care home would be less likely to contract it than somebody living in any other setting just didn't make sense in terms of that guidance.
And to your knowledge, did that pose any risks or cause any issues for staff trying to implement the guidance?
Yes, because if the guidance is suggesting that it's a low risk environment, but you feel that it isn't, and you're struggling to access things like PPE, those things add up to making for a very difficult situation for an individual nurse who's wanting to implement that guidance, or a manager, an operator of a care home who's wanting to implement it to keep their staff and their residents safe.
And the next guidance from Public Health England was published 11 days later on the 13th of March 2020. If we may have it on screen, please. It's INQ 30325-233, page 3. It's at tab 9, should you need it in the bundle. Now, this guidance recognised that much of the care delivered in care homes will require close personal contact. There was a change in the guidance there. And then if we can go down to page 4, please. It recommended that staff should use personal protective equipment, PPE, for activities that bring them into close personal contact. And then just further down the page, 4, thank you. It said that no PPE was required unless the care worker or recipient of care was symptomatic. Was the RCN consulted or engaged by Public Health England or DHSC around this time to provide any expertise or input into the guidance?
I'm not aware, but it may be something that a colleague could answer.
Thank you. Looking then at this advice, was it clear enough for those that were trying to implement it on the ground, as we've just discussed, as to when and what PPE they should in fact wear?
No, because it still refers to not requiring PPE if an individual is asymptomatic. It refers to the use of things like fluid repellent masks and face coverings, but it doesn't acknowledge other aspects of care that may be delivered. So it's certainly still not clear enough and specific enough for care sector for the reality of what happens. And although it does recognise in this guidance that care is delivered in close proximity to individuals, it still stated that if an individual was asymptomatic, that PPE wasn't required.
Now that is obviously focused more on care homes, and just staying with the chronology, you have explained in your statement that the RCN was invited by the Academy of Medical Royal Colleges to comment on PPE guidance for secondary care, again produced by Public Health England, and that's at the end of March 2020, so a couple of weeks on now. And it may help to have your response to that on the screen. So that's INQ 30587 paragraph 50, page 54, paragraph 189. Thank you. So you say that the RCN was astonished at the limited nature of the draft revisions of PPE guidance, in that it continued to apply to acute hospitals only. The RCN highlighted the absence of consideration for those nurses and healthcare assistants working in the community to the CNO, Chief Nursing Officer, I assume for England, via email on the 28th of March 2020. So in the RCN's view, was there adequate guidance for staff working in the community at this time?
No. At this point, the guidance was very tailored towards acute hospital settings, so it didn't recognise social care and other community settings.
Did you raise those? Obviously, you raised them with the Chief Nursing Officer for England. Did that get any response?
Not that I'm aware of.
So approximately a month later, on the 27th of April 2020, was the publication by Public Health England of How to Work Safely in Domiciliary Care Guidance. Can you recall whether that allayed your concerns about any gap in the guidance?
I don't know. It may be in my witness statement. I can't recall.
Okay. That's fine. If just returning then for a moment to earlier in April 2020 and dealing with the topic of asymptomatic transmission and infection, which you've referred to, you say in your statement that the RCN highlighted the emergence of evidence suggesting COVID-19 was being transmitted by asymptomatic carriers with Health and Safety Executive at the start of April 2020. Do you know if that was also raised with the Department of Health and Social Care and or Public Health England in the context of the adult social care sector at that time?
I think it was. I think one of the issues that came up quite a lot is that we would raise things, but we wouldn't necessarily receive acknowledgement or receive a response to things that were being raised. So we were quite persistent in raising things, and certainly in the written evidence, we have provided many examples of where we have raised things with various departments, but we haven't always, to the best of my knowledge, received a response to that. But then there have been changes to guidance subsequent to it. So there is at least hope, I think, that our concerns were being addressed. And I appreciate that at the time everybody was incredibly busy and probably didn't necessarily have time to be replying to emails.
Perhaps quite a broad question, but are you able to help us as to when the RCN says that the risk of asymptomatic transmission should have been included in the guidance?
A specific date?
Well, is it earlier than in fact the period that we're talking about?
It was very early on in the pandemic that we raised those concerns. I think it was even prior to March, that asymptomatic transmission was very clearly becoming apparent through the evidence, and that didn't seem to be getting taken on board.
What about the issue that age was very much a risk factor? And obviously an awful lot of people in care homes are likely to be of a particular age. Was that an issue that the RCN raised, and therefore you oughtn't just to be looking at acute health settings because of the age being such a predominant risk factor?
We raised that. We raised around other demographics. We raised around demographics of the workforce, because certainly the social care workforce is a slightly older workforce and therefore at increased risk. The social care workforce is also more diverse in terms of minority ethnic groups than general population, and we raised that because the minority ethnic groups were also groups where the risk factors were increased. So we were constantly raising these various risk factors and issues. Nursing is an evidence-based profession, and the evidence was all pointing towards these various risk factors, including the asymptomatic transmission.
Thank you. Just finally, on this topic, do you know if the RCN are working with UXA now to develop IPC guidelines for the sector in case of a future pandemic?
I'm certainly not.
Not aware?
No, well, I'm not aware, and I'm certainly not working with anybody, but we do have a professional lead for infection prevention and control. So if that was ongoing at the moment, it would more than likely be that person who would be doing it. So I can certainly find out for you.
Thank you. Are you aware as to whether the RCN and its members had a relationship with health protection teams during the pandemic?
The RCN has regional offices, and there will be areas of the country where there are stronger regional relationships, and health protection teams are, in the main, regionally based. So there will certainly have been areas where there was stronger relationships than in other areas, but I think that's probably quite indicative of many things.
Do you know whether they were overall supportive and helpful in helping kind of care home providers, but also staff implementing guidance and undertaking risk assessments where that was advised in the guidance?
I think, again, that was quite regionally inconsistent. So there were some areas where the support for implementation of the guidance was very strong, and there were some areas where maybe it was less strong. And I think that this was one of the reasons why having really clear guidance that was produced from the centre was so important, because having regional inconsistencies around the support to understand the guidance just makes it even more confusing and muddies the water even more. But in the absence of having very clear, very tailored guidance, there was certainly value from where there were strong working relationships with regional and local health protection teams.
And just bringing these two topics of the workforce and IPC together, I'd like to ask you a little bit about training and education for the workforce in this area. You say in your statement that the care home sector was unprepared psychologically and physically for the realities of residents and staff becoming infected, and how this might be managed in a largely unqualified workforce with limited IPC expertise, education, resources and equipment, including the use of PPE. And you have also included the results of an RCN survey which showed that only 52% had reported receiving training on what standard PPE to wear and when. In your view, was there sufficient training on the use of PPE for nurses working in adult social care before the pandemic?
For the use of PPE for the care that they were delivering day in, day out, yes, probably. But this was a very, very different situation. And I think the context of what social care is, it's an individual's own home. And whether that is receiving care in their own place of residence, where through domiciliary or home care, or living in a care home, they're not acute hospital settings. So you would use PPE if you had an outbreak of something like norovirus, but you wouldn't routinely be using high levels of PPE. So there wouldn't be lots of routine training in the use of PPE in a hypothetical respiratory pandemic situation. So no, it probably wasn't adequate, but yes, it probably was adequate for the levels of care that were going on day to day. And I realise that's a very vague answer, I'm sorry.
Do you think it would be helpful to have that training embedded in normal times in preparation for a future pandemic, should there be one?
Absolutely. I think that would be a really good thing to have for future pandemic preparedness, to have that background knowledge of what you may have to step up and roll out quite rapidly to have that background knowledge and training in place would be very beneficial.
To cope with the pandemic, which may have a virus with different characteristics, the training is going to have to be, this is what you have to do for this kind of virus, this is what...
Potentially, yes. And I don't think it needs to be particularly extensive training, but I think there needs to be a basic background level of training and understanding, and then the ability to roll out rapid training. It's so difficult to be able to predict what any future pandemic characteristics may be like, but there does need to be a background level, I feel.
And would you include domiciliary carers in
Absolutely, that they are a fundamental part of social care.
One of the packages that was introduced in England around May 2020 was the Enhanced Health and Care Home package, which delivered additional IPC training for every care home from the NHS. Do you know if the RCN was consulted or involved in the implementation of that programme?
I think we have been involved in enhanced health and care homes throughout. Again, this was another thing that it is centrally created, but the delivery of it is delivered within individual locales. So there is kind of, it isn't necessarily 100% consistent, that delivery across every area.
A topic that the inquiry has heard much evidence about over the last few weeks is that of movement of staff between care homes and to a much lesser extent in domiciliary care. In the first, in early guidance from Public Health England on the 13th of March 2020, which we were looking at before, the guidance was for care homes to share the workforce between providers and services. Do you know if the RCN had any views on that at the time that it was published?
I think the concerns that the RCN has around that are twofold. One, the kind of infection prevention control aspects of it, the professional nursing aspects, but also the fact that, as I mentioned earlier, social care employers make up tens of thousands of different organisations with tens of thousands of different sets of pay terms and conditions for their workforce. So it isn't necessarily feasible to expect individuals to be working across different employers as well as different workplaces.
And you have referred in your statement to some of the concerns that you had around proposals to regulate movement between care settings. Could you perhaps just explain to us what were some of the practical difficulties in reality that you saw with those proposals? Were they implemented? Should they be implemented?
So the social care workforce is predominantly female. It's made up of many people who have part-time contracts or 0 hours contracts. People may have multiple roles at different employers. And some of this is by choice because that fits in with an individual's work-life balance. They choose to have jobs where they may work some days at one care home, an evening at another. Within the NHS, for example, it's really common for people to turn up at work and be told, oh, we're overstaffed on this ward, please can you go and cover the shift on the other ward. That's the same level of movement of staff as people going from a care home to another care home. But the guidance was to restrict that movement between care homes, which isn't feasible for the workforce and ultimately risks leaving individual recipients of care without their care being delivered.
You've referred already today to some of the issues around access to PPE, and indeed you've included many examples in your statement. You've also included, many examples around when you raised those concerns, both centrally with central government and local government and public health as well. So can you help us with whether those concerns led to any changes or improvement in access to PPE?
I don't know whether we could attribute us raising our concerns to changes that were made in accessing PPE. I think there were changes that were made, and those changes that were made after we'd raised concerns, but whether or not we could confidently say that was as a result of what the RCN did, I don't know.
You have also included in your statement the results of the April 2020 PPE survey by the RCN, which received around 1,300 responses from adult social care, in which approximately 58% of respondents said that they had felt pressure to care for a patient without adequate PPE. So do you think there was adequate access to suitable PPE available in the care sector during that period of time in the first wave to allow staff to follow the guidance that we've been discussing? No,
definitely not. I think we have numerous stories, numerous examples, many of which have, as you mentioned, have been included in the witness statement, of members reporting that they were unable to have access to adequate PPE. So I think the voices of our members very much would say no, that there was not adequate PPE available at that time.
In terms of improving access, you've provided a couple of examples of how it improved in the devolved nations. So in Wales, you've referred to the establishment of cells by the Welsh Government assisting with access, and in Scotland, the introduction of the social care triage hub. So in both of those examples, how did they improve access? And in future, do you think that they could be introduced sooner to make sure that there's access at an earlier date?
I think in both of those examples, and in examples in England as well, with having central procurement, they certainly improved the situation, and definitely the sooner the better. Put most simply, the way they improved it in the main is that they helped individual care provider organisations be able to overcome the issues that arise of just not having the buying power. If you are a small home care provider or care home, fighting in a market to be able to procure PPE when the other people that are trying to buy the same PPE are a massive NHS trust, you don't have the buying power to be able to do it. And the cells and the triage system and central procurement routes went some way towards overcoming that.
And is it right that you have recommended that adult social care should be considered in pandemic stockpiles, or that there should be a system by which the care sector can rapidly access sufficient PPE in a future pandemic?
Absolutely.
Moving on then, if I may, to testing, what were some of the barriers or issues that your members faced with access to testing, and how did that compare to those that were working in the NHS, perhaps?
So, as I mentioned earlier, the ability to be able to access a test was very difficult. Members working in the NHS were able to access tests through their occupational health, through their hospitals in the main, if they worked for an NHS trust with a hospital base. So it was just very, very difficult for members of the social care workforce to be able to access tests. In fact, in order for them to be able to access tests, in the main, bar a few exceptions where some NHS trusts did open up their testing routes to social care staff, the social care workforce was accessing tests in exactly the same way that the general public were.
Mm. And you have recommended that there be parity of testing in the care sector with that of the NHS in your statements, is that
Absolutely.
Right? Just staying on the topic of testing for a moment, and I'm at paragraph 100 of your statement, should it assist you. But on the 16th of April 2020, the RCN asked the Care Inspectorate Wales to launch a review into actions taken or not taken in relation to care homes. And they responded about a week later. indicating that although it was not within their gift to secure testing, they had been seeking testing for residents and staff in care homes for several weeks. Firstly, are you able to help us with what led to the RCM requesting that review?
Reports from members.
And were you satisfied with that response?
I don't... The response wasn't ideal, but the response was honest. So they provided a response. It's better than nothing.
I think you've explained how in September 2020 concerns around access to availability of testing continued. So is it fair to say that the situation didn't improve until later on in 2020 in Wales?
It took a long time for it to improve. And I think where it did improve, it improved slowly.
Moving on to a different topic, and that's DNA CPRs and advanced care planning. Now, is it right that the RCM was involved in a UK government ministerial oversight group on DNA CPRs and advanced care planning from around June 2021?
Yeah.
Did your involvement in that group make any meaningful difference or see any changes in those areas? And can you provide some examples of the issues that were discussed?
I don't know particularly whether it provided any meaningful impact. I can certainly find out for you. Obviously, it predates my time at the RCN. I think certainly in terms of DNA CPRs, we were able to communicate what we were hearing from our members. We didn't hear widespread reports of DNA CPRs from our members, but there are many potential reasons why that might be, and they probably are in the realms of hypothesis, really. But residents, certainly of care homes where nurses are delivering care, are people who are often very frail and often possibly approaching the end of their life anyway. So the people with the highest need and therefore probably most likely to already have a DNA CPR in place would be residents of the services where our members are more likely to be working. So it wouldn't be abnormal for our members to be seeing quite high levels of DNA CPRs in their day-to-day roles.
And for that reason, do you think it would have been helpful to have that sort of involvement in such a group earlier on in the pandemic?
I think so, definitely.
The inquiry has heard through its Every Story Matters about the integral role of district nurses in delivering end-of-life care at home during the pandemic. We don't need it on screen, thank you. So that was one of the quotes, but thank you. Was there a change in responsibility for nurses in care homes and district nurses in delivering end-of-life care, including, for example, administering medication or facilitating access to healthcare during the pandemic?
I think nurses working in nursing homes are very used to delivering end-of-life care for individuals. Residents of care homes without nursing would be probably calling upon usually NHS nurses, so district and community nurses, to provide that support. And I think that there were certainly times when it was difficult for health professionals to be able to attend in some social care settings because of restrictions that were put in place.
Do you know if the RCM was approached either by central or local governments or care and nursing homes directly to provide training to staff who are being asked to take on more clinical responsibility?
I don't, but we do produce lots of training resources, educational resources, and many of those resources are available to all nurses and nursing support workers, not just RCN members. So we do make a lot of our training and resources available for people to access without having RCN membership.
Professor Sleeman and Professor Barclay, experts to the inquiry, have explained how training on end-of-life and palliative care for nurses is not mandatory once qualified, and that training is essentially up to local arrangements and funding dependent. So do you think embedding such training for all care professionals in preparation for a future pandemic would be beneficial?
Absolutely.
Lastly on this topic, the RCN with Marie Curie and other organisations developed an end-of-life community charter in March 2020, which included ethical guidelines for best end-of-life and palliative care during the pandemic. What led to you developing those principles in the charter?
The voices of our members, the clear need for that to be provided so that our members and the wider workforce were equipped with the best guidance and knowledge to be able to provide and deliver the care that they were doing.
And to your knowledge, was it used in practice?
I think so, yes.
Moving on to a different topic, and that's staff pay. So in the RCN survey undertaken in 2020, this topic was covered, and 48% of nursing staff working in the sector said that improved sick pay or leave would have made them feel more valued. And 89% of Black and 78% of Asian respondents working in adult social care were worried about their financial circumstances, and that was higher than those working in the NHS. So were concerns raised by the RCN around statutory sick pay for those working in the sector, and perhaps the impact that had on self-isolation decisions?
Yes, we raised that.
Do you feel they were listened to and acted upon?
Possibly. It's, as I mentioned earlier, it's very difficult to say because obviously this was a very rapidly changing time and things were changing, and it would be fantastic to be able to sit here and say, we said this, therefore this change happened. It must have been because we said it. But actually, I suspect lots of people were raising the same concerns at the same time, and I hope that our voice was a part of what caused changes to happen.
The inquiry has heard how a statutory sick pay scheme in Wales was introduced later than the rest of the UK. Did you hear any concerns about that specifically?
Yes, so we had members contacting us throughout, expressing their concerns about their worries about their financial situation, and we were continuously raising this with all four governments to try and contribute to the discussion to improve the situation for the social care workforce.
And then in regard to the Infection Control Fund in England, in your experience, was there widespread access to the fund for those actually on the ground, and was it effective, essentially, in limiting staff movement?
I think it was very difficult for people to access it. It was a very complicated process to be able to access it, and I think that the limiting of staff movement, as I've mentioned, isn't always necessarily feasible, and I don't particularly think that the fund was easy for the workforce to be able to access to support that.
And then in regards to psychological support for the workforce, you have set out a number of initiatives and guidance in your statement that was issued nationally during the pandemic to support adult social care staff with mental health and well-being. You have also said that access to a support package from the government for adult social care staff was later than that for the NHS, is that right?
It was.
And in September 2020, the RCN called for access to support and counselling to continue. Did it, in fact, continue?
RCN's counselling service, or?
Sorry, no, that was around the support package that was provided.
I don't know
Okay.
to what length that continued. I know that there was certainly some, again, regional differences. So some areas, the NHS opened up their services to social care employers and workforce within their locations. I think that certainly there was a point when NHS could access things quite readily, and it was very difficult for social care staff to be able to do that. There was access to there was a particular app that had been developed that people could access. You needed an NHS email address to access it. So whilst nobody explicitly said you couldn't have it, and in fact people were saying, yes, you can have it in social care, but it was just so difficult to access that it just became an additional barrier. So I think that we talk about having an integrated health and social care system. The Department of Health and Social Care oversees both aspects and working together to provide that support for individuals. But the equity of access seems to be so difficult to get on a level playing field that I think that needs to be considered for future. How would that be opened up to ensure that the 1.6 million people in social care can access the same as the 1.4 million people that work in the NHS?
I think another framework or area of support where it was also rolled out in adult social care after the NHS was the Adult Social Care Risk Reduction Framework. Now, this was intended for employers to support vulnerable workers, but also to encourage employees to make decisions about their risk of infection and possible adverse outcomes from COVID-19. And I believe the RCM was asked to review drafts of the framework in around May 2020. Are you able to help us with what feedback you provided and whether that was reflected in the final framework?
Certainly we've fed back that initially it was very acute hospital focused, and that it needed to be much more recognising of the diverse settings across health and social care in order to be of use for the workforce.
And do you think that was achieved in the final version of the framework?
It was better.
Do you know whether it was widely used or accessed?
I don't know whether it was widely used or accessed, but I suspect that would probably be the authors of it might be the best place to answer that.
The RCM produced a COVID-19 workplace risk assessment toolkit, not until December 2021, so sometime after. Was that for use in adult social care as well?
Yes. So I think, although that launched quite late, that was a culmination of lots of other things that were launched iteratively throughout the process. That was kind of pulling it all together into a very neat toolkit that indeed continues now.
And was that produced in response to what you were hearing from your members as well?
Absolutely, and in the absence of very clear, straightforward guidance that was applicable to relevant settings from other sources, we were producing our own guidance, and as I say, by December 2021 had collated that into the toolkit.
You have set out a number of recommendations in your statement, and we have already discussed a few today. Are there any others that you wish to draw to our attention this morning?
I think, for me, if I could wish for three things for the next pandemic, because it will happen, parity of access, equity of access to training, to testing, to PPE, to ensure that health and social care are on an equal footing. That the workforce capacity, whilst it is outside of the scope to be able to fix it here, if there is more recognition of the social care workforce, then there may be more sharing of that expertise across the settings. Yeah.
Thank you. My lady, those are my questions. I believe
Thank you very much, Ms Hans. I think the first question is Ms Campbell, who's just there.
Thank you, Milady, and thank you, Ms Sutton. I ask questions on behalf of the Northern Ireland COVID bereaved Families for Justice. And my question focuses on the issue of communication between you and your colleagues and the Northern Ireland Department of Health. And so it's important that I should preface the question with the reference that's in your statement, we know, and also in your evidence this morning, that generally communication between the Department of Health and the RCN or your colleagues in the North was positive. In fact, at times you indicate it was excellent, particularly, I think, at the early stages of the pandemic.
Yes.
But at paragraph 433, towards the end of your statement, and you're dealing at this point with autumn 2020, you refer to a series of lack of responses from the Northern Ireland Department of Health to your colleagues, the Independent Sector for Nurse Management Managers Network, ISNMN, about concerns around two things. The first was the changes to the testing regime in care homes, which had come in without any engagement, you indicate, with care home representatives on the 3rd of November of 2020. And in relation to that, you indicate that there had been correspondence issued, I think, on the 6th of November, followed up on the 9th of December, followed up again on the 7th of January 2021, and no response received. Do you recall that aspect of your statement? Mm-hmm. And you also refer to correspondence around the same time and queries about the care home implementation arrangements, which required care homes to provide monthly updates on the implementation of guidance, including care partner guidance, which we know was issued around this time. And there was correspondence on the 15th of October, the 22nd of October, the 30th of October, the 1st of December, and attempts to arrange a phone call on the 15th of December, which were ultimately unsuccessful. So, against a background of positive communication at earlier stages, do you agree that, firstly, these issues of testing in care homes and the implementation of arrangements around care partner guidance were not just interrelated, but were amongst the most pressing issues facing staff in care homes in autumn 2020 as we go into the second wave?
Absolutely, and the Independent Sector Nurse Managers Network is a group of RCN members who are independent sector nurse managers. So they are managers of nursing homes, and they were very much telling us that those were issues at that time. And
there were issues of such significance that your colleagues in the Independent Sector Nurse Management Network or Managers Network might reasonably have expected replies and engagement from the Department of Health. Is that right?
Yes.
Well, how do we interpret then the non-response that you indicate that there was? Does it reflect that around this time there was insufficient engagement on these important issues from the Department of Health?
Certainly that lack of response shows that, yes.
Do you know whether a response was ever received in a constructive way around either of those two issues, the testing and the implementation of care partner guidance?
I don't personally, but I can certainly find out.
Thank you. Thank you.
Thank you, Ms Campbell. Now it's Mr Stanton, who's over there.
Thank you, Melody. Good morning, Ms Sutton. I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. I have questions on two topics, both specific to Wales. First, at paragraph 208 of your witness statement, you state that there were initial difficulties engaging with the Welsh Government, and that's something that you'd mentioned earlier already in your evidence, and that it very much seemed that care homes were a second thought after the NHS in Wales, again, something you've dealt with already. Are you able to give an indication of the action taken by the RCN to encourage the Welsh Government to treat care homes as a higher priority, and of any responses you received from them?
So we did, the director for RCN Wales did write multiple times to the Welsh department. And to the best of my knowledge, at times did not receive responses. I think that we were very, very keen and pushing often to be included in conversations. And certainly once the cells were created, there was more interaction there. But yeah, I don't know, does that help?
Yes, it does. And is that the nature of the initial difficulties that you mentioned, or is that something separate?
No, I think that is the nature of it. I mean, I think it's very difficult because obviously the context is that at the time everybody is so incredibly busy and everything is changing all the time. But it still requires that engagement with, we are the voice of nursing. We can be there to represent the issues that are facing the profession and our membership in particular. And it did feel to the organisation at times that it was really pushing on a locked door. And it took persistence to be able to get through that.
Thank you, that's helpful. The second topic concerns the suspension of inspections. And at paragraph 100 of your statement, you refer to a request made by the RCN on the 16th of April 2020 to Care Inspectorate Wales to carry out a lessons learned exercise once suspended inspections had been resumed to identify best practice and avoidable harms. However, Care Inspectorate Wales declined to do so. Having regard to the suspension of inspections and the subsequent refusal to carry out a lessons learned exercise, do you think Care Inspectorate Wales provided sufficient oversight of care homes in Wales in order to safeguard residents' rights and quality of care?
I think the initial suspension of inspections, that decision was made based on risk and the risk to individuals residing in care homes and working in care homes, but also the risk to inspectors of going across multiple locations. I think key is that declining to address the lessons learned and to analyse the success of that. And I think that you need to be able to do that in order to be able to learn from something. You have to be able to reflect upon it and learn whether it was the right decision. And so, yeah, does that really answer your question?
Yes, it does. Thank you very much. Thank you, my lady.
Thank you, Mr. Stanton. Next, I think we have Mr. Straw, who's that way.
Just wait for it to come on. There we go. Yep. Thank you. Ms. Sutton, I represent John's Campaign, the Patients Association and Care Rights UK. At paragraph 383 of your statement, you share stories about staff stepping in for families at the end of life. For example, and I quote, what I as a nurse struggled with most was when we had people approaching the end of their life, we were the only source of comfort and support they had in between attending to our other residents. We were the only ones allowed to be there to hold their hands, to tell them it was going to be okay. And we also had the duty to convey information to family members who were left helpless at home, standing at their loved ones' windows in all weathers, not being able to say a proper goodbye, to tell them they love them and hug them one last time. Do you agree that meaningful contact with loved ones at the end of life should have been facilitated to mitigate these difficulties caused to nurses, as well as the serious harm caused by the separation to the dying person and their loved ones?
Definitely.
And can you help us with what specifically should have changed to better facilitate that contact? Was this a problem with the guidance being too restrictive, or how it was interpreted, or what should have changed?
I think nurses are very good at carrying out risk assessments. And I think had there been flexibility in the guidance to enable nurses to be able to ascertain whether a visit at that time was safe and could be facilitated, then nurses would have been ideally placed to be able to make those decisions with the best interests of those residents, their loved ones, and their staff in mind.
So could they have been in a good position to do the balancing exercise between the harms on the one side caused that are explicit in the quote that you have in your statement, against the risks from COVID and so on that there might be of allowing visitors?
Yes, and I think it would be individualised to each person. You would make that risk assessment for that individual resident in their situation rather than blanket decisions.
Thank you. A different topic. I'd like to ask about people providing essential care, so as distinct from social visitors. Would you agree that an essential carer should have been treated as part of the care team and therefore have always been given access to the person they cared for?
Yes.
And how could that have been better facilitated?
Again, I think nurses are ideally placed to be able to make risk assessments and be able to facilitate things in the safest possible way in that individual setting. Care homes, for example, are all different. Some of them are huge purpose-built buildings. Some of them are very small, converted Victorian homes. The nurses, the managers, the people who are operating those services are the people who know that building, they know their residents, they know their staff, and they are able to make a decision to be able to facilitate things in the safest possible way to the best outcomes for their individual residents that they're supporting.
One factor that my clients have drawn attention to in this context is that if an essential carer is allowed in, that takes the burden off other staff or other nurses. Again, would that be something that nurses would be in a position to assess and understand and balance?
Yes.
At paragraph 393 of your statement, you identify problems in some Scottish care homes. For example, you refer to a 16-bed dementia unit where staff shortages and high agency usage caused things like lack of continuity, poor handovers, concerns about compromising person-centred care. If essential care supporters had been given access and treated as members of the care team, would that have alleviated some of the pressures that you've described?
It may have done.
Were these issues in Scotland representative of broader experiences reported to you by your members?
It's certainly something that members did report across the UK.
And did in response to this type of feedback, did the RCN take any action? And if so, what was that action?
We did report the thoughts and the expressions of our members to the respective governments, and we did make it clear that nurses are really well placed to be able to support these things happening in a safe way.
Okay, those are all my questions. Thank you very much.
Thank you very much, Mr. Straw. I should probably say this, but if only more witnesses just said yes or no to a question. Thank you very much indeed for your help, Ms. Sutton. It has been extremely helpful. I know at times you've apologised if you've not known the answer. I promise you I'd far rather have that response, I don't know, or rather than people making confident assertions which aren't based on evidence. So it's been extremely helpful. Thank you for the help that you've given to the inquiry and for coming today. And thank you to any help. I don't know if colleagues helped you prepare your statement.
I did.
And thank you to them as well. Very well. I shall return at 11:30.
All rise.
Ms. Paisley.
Lady, the next witness is Helen Wildbore.
Okay, if you repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Take a seat.
Thank you for coming to help the inquiry, Ms. Wildbore. I hope we haven't kept you waiting.
Thank you for for attending to give evidence today and for providing your witness statement dated the 2nd of December 2024. And that statement has been co-signed by Rachel Power on behalf of the Patients Association and Julia Jones on behalf of John's campaign. Is that correct?
It is, yeah.
Can I deal firstly, please, with the broad overview of the three organisations, noting, of course, that there is a lot more detail provided in your statement. You are Director of Care Rights UK, which was formerly the Relatives and Residents Association, which is a charity focusing on the rights of people in care. Throughout the pandemic, you state, our small team worked tirelessly to provide support and share the voices of people seldom heard and raise their issues and concerns. You also explain that Care Rights UK has an advice line, and through that it was in direct contact with individuals at the sharp end of the pandemic, which has given Care Rights UK a unique insight into the experiences of families dealing with COVID-19 and measures taken to manage it. Can you please assist us with whether your organisation had a focus on any particular nation during the pandemic, and if that is still the focus today?
So when we were the Relatives and Residents Association, during the period that the inquiry is interested in, we were focused on England. As Care Rights UK, we now have expanded our focus to be UK-wide.
Can I just ask you to keep your voice up ever so slightly? I don't know if it's possible maybe if the microphone could come any further forwards.
Is that better?
That's better, thank you. Would it be fair then to say that your evidence has been informed by many real-life accounts of people drawing on care and their loved ones throughout the pandemic?
Yes, so you mentioned we're a small team. At the time, we had 2 advisors running our advice service. We handled around 2,000 calls and emails with bespoke one-to-one advice for people, providing further support as requested, as needed around kind of letter writing, etc. And for some people, we supported them for many months, sometimes years, as the issues persisted. And we would hear from people every day who were facing the anxiety, the trauma of what was happening in care settings, mostly hearing from the relatives and friends of people supporting people needing care, but sometimes directly from people using care services directly. And it was so difficult in preparing this to try and think of which stories to share with you, which voices to share, because every day we were hearing the devastation and the loss and the irreparable damage that was happening inside care settings.
And we'll go through a number of the voices that you have shared. In respect of the co-signatories to the statement, Julia Jones is the co-founder of John's campaign. And John's campaign, their initial focus was to ensure that the family carers of people with dementia in hospital were always welcome to support them. And it now campaigns for a legal right to a personal care supporter for every individual. And its values are get it right for dementia and you get it right for everyone. And it continues to support vulnerable people and their families within the health and social care system. Is that correct?
It is, and we are campaigning with them for that change in the law around a right to a care supporter. It's a joint campaign alongside Rights for Residents.
And Rachel Power is the Chief Executive at the Patients Association. That was founded in 1963, and it's an independent charity campaigning for improvements in health and social care for patients. It's dedicated to supporting the rights and interests of all patients and their families. The first topic I'd like to ask you about, please, are the 3 organisations' major concerns regarding the adult social care sector going into the pandemic. And in your statement at paragraph 25, you explain that the structure of adult social care in the UK is complex, confusing, and often not fully understood by those who work in the sector, let alone those who rely on it or make policy in relation to it. What concerns did this give rise to insofar as how your organisations felt that decision makers would be able to understand the sector and make key decisions in respect of it?
So we had a lot of concerns before the pandemic, during the pandemic, after the pandemic, about the lack of understanding of social care, from the very top of government through the civil service. The sector is hugely diverse, both in terms of the types of care settings, people getting support in care homes, supported living, support in their own home, rehab centres, etc. But it's also very diverse in terms of the people who need support. And that diversity spreads across the type of support that they need, as well as age and the different needs that people have, very individual needs. And from our perspective, as well as our core participants, we support people to navigate through that maze of most people don't think about social care until they need it. And often when they need it, they can be in a point of crisis with lots of emotions running around. People can often feel a lot of fear about the future in social care. But also from a kind of relatives and friends perspective of the people supporting that person needing care, there can be a lot of guilt around they might have been providing that care themselves as a family carer up until that point. And I think the pandemic just made all of that a lot worse. And I think the guidance that we saw coming out during the pandemic really just demonstrated that lack of understanding of the sector.
And do you think understanding the complexity of the sector is something that needs to be focused upon in pre-pandemic planning, for example, and should there be more engagement with stakeholders at the stage before the pandemic actually hits?
Absolutely, and I don't think that you can understand social care until you understand what it's like to be a person who is relying on social care and relying on care and support services to live an independent, dignified life. And so I think there needs to be much more understanding within the government and within the civil service. And I think that involves training for the people who are making those policy decisions that have such an impact further down the line on people's lives. And I would say part of that training should be very hands-on, practice-based, and it should involve speaking directly to people who are using and relying and drawing on care and support services and the family and friends about what that feels like and how those policy decisions do impact them.
In paragraph 28 of your statement, you confirm that Carers UK estimated that by June 2020, there were a total of around 13.6 million unpaid carers. Going into the pandemic, what do your organisations feel were the main risks surrounding unpaid carers and how they may be impacted by the response to the pandemic?
I think our concerns about what was happening to unpaid carers were very similar to our concerns about what was happening to people who are drawing on care and support services, in that it was very clear that that lack of understanding of the sector that I spoke about and how that impacted the policy decisions that were being made and the guidance that was being written. We were concerned that there was a huge gap between what was happening at government level to make those decisions without people in those rooms who really understood social care. And I know other witnesses have spoken to that about the representation of social care when those decisions were being made. And what that meant for the people on the ground who were either relying on care and support to live a dignified life and the people supporting them at home, family carers, to live a dignified life. And the gaps that they were having to fill that were left by neglect of social care over many years by many different governments, the lack of support for people who need care and support, and the lack of support for those family carers. And I think we saw that play out during the pandemic, and we saw the devastation that is caused when you don't understand a sector, you're making decisions about that sector that you then don't follow through and monitor what's happening on the ground and the impact of those decisions. And you're not talking to, engaging with, or even listening and hearing people who are at the very sharp end of those poor decisions. There was very little engagement with people directly who were being affected. And even when they raised their voices through organisations like myself and the other campaign groups, the stories were there, the impact was there. We knew what was happening and they were shouting about what was happening, but still it didn't lead to any change in policy. It didn't lead to any change in even understanding about the sector.
And just 2 more points on going into the pandemic, please. At paragraph 32, you explain that all 3 organisations had concerns that social care has traditionally been viewed as isolated from and separate to healthcare services. And concerns were also held regarding the prioritisation of healthcare over social care. How do your organisations feel that that affected the early response of decision makers in the pandemic?
I think the focus seemed to be on institutions. And I think that led to a lot of very poor decisions being made. And that had a terrible impact on the ground for people who were relying on care and support services.
Is it possible to perhaps give an example of one of those poor decisions, please?
So I think the messaging around protect the NHS led to policies that were detrimental to people needing care. It put people's lives at risk. For example, the decision around discharging people from hospital into care settings without testing. And I think what was lost sight of is the fact that these services exist to serve people. And in future, a change that is definitely needed is a focus on people, not institutions, and a focus on the people who are most at risk and the kind of services and support that they need and how those services need to protect them. And I think, again, engagement with people who have lived experience of those services and social care needs to be as highly valued as NHS and health services. And there's lots I could say about that in terms of the reform that's needed of social care. But I think we were coming into the pandemic in such a poor place with social care. And that those problems just got worse during the pandemic. And we still see them today.
Can I just pick up on the point you raised about protect the NHS and the messaging? Do you think then it would be useful going forwards if there were similar size campaigns that focused on the care sector, or do you think joint campaigns may be a way forward? So specifically on messaging, how could that be addressed?
I think the messaging needs to focus on the people. It shouldn't have focused on any institutions because, as I say, those institutions are only there to serve people. The whole point of the NHS and the whole point of care services is to support people to live well and to support them with problems that they have with their health and any kind of support needs that they have around care. So it should never be about the institutions. It should be a focus on why they exist.
And just finally on this point, your statement outlines that for years your organisations have worked to emphasise the importance of including those who draw on care in the very decisions that will impact upon them and affect them, and equally the significance of including their relatives or representatives in those conversations. Had there been a greater focus on person-centred care and had it been more recognised, are there any particular decisions you think that may have been different?
Well, what we saw was that person-centred care was just completely lacking in the approach that was taken to the pandemic. Person-centred care is about treating people as people and not as objects to be moved around, not as statistics. And I'm afraid that is the approach that we saw that was taken during the pandemic. And I think the public health response failed to see people with their as holistic people in terms of their holistic health and well-being. And there was far too much focus on protection from the virus without balancing that against the protection that was needed from the very measures that were being put in place to manage the pandemic. And I think there was a kind of lack of understanding of the support that loved ones provide. So guidance that was saying from March 2020 to stop all visits from family and friends, but then couriers, in the guidance it said couriers were still allowed to visit as long as they wash their hands. I mean, that lack of understanding of the caring, what that caring role is and how it's fundamental for that to continue. And other guidance was making exceptions for that. We saw in hospital guidance that there were exceptions for family carers, and there were exceptions around if a person would experience distress without, the support of their carer. And it was far too late in the pandemic that we finally saw that coming in guidance for care services around, I think it wasn't until December 2020 that it first recognised essential carers. And then the essential caregiving role didn't come in until March 2021, which was a whole year after the pandemic had started.
And I want to ask you more questions about that in detail. But just before we move to that topic, can I ask some specific questions, please, about the work that Care Rights UK was involved in during the pandemic? And we've already touched upon the advice line at the start of your evidence, and you explained that that was a vital source of support for people. Was Care Rights UK able to take those accounts and feed them into the government at all?
We were trying. So I have some. I pulled out some to remind myself before this. I pulled out some of our engagement. The former care minister came and gave evidence to the inquiry and said that there was no representation for people in care during the pandemic. And I think that just speaks to the kind of lack of awareness of the sector, because as we've seen during this module, there were organisations providing that voice, they just weren't engaged with. And so from our perspective, as we were then the Relatives and Residents Association, we had been around for 30 odd years providing that advice service for older people needing care. And we had been writing to the government and the regulator from quite early on in the pandemic, in May 2020. And it wasn't until John's campaign took legal action against the government guidance. And as part of that, dropping that legal action, they insisted that the government listen to and engage with us. So at that point, we were finally asked to join the COVID adult social care working group of stakeholders in the summer of 2021.
If I could just pause you there, in fact, that's my next question. Yeah. And I understand it was quite late, in fact, during the pandemic that Care Rights UK were involved. Can you provide a broad overview of that group? What was it useful? Would it be useful for the future?
So my understanding was that that group had only been set up to deal with the pandemic, and then it ceased. I can't remember when it ceased, but I can provide dates because I've got an email trail with me pleading with the government not to close that group, because at that point when they closed it, there was still guidance that was still having a terrible impact on people's lives in adult social care.
That's something you touch upon, in fact,
yeah.
I think in your statement for anyone listening. Was it effective while it lasted?
So when I joined by summer 2021, my reflections of it are that by that stage, risk-averse approaches had already been so embedded across the approach to the pandemic that it took immense efforts to get even small changes and even small shifts in approach. So if I could just give an example, there's an iteration of the government guidance. It was being reviewed in October 2021 of the visiting guidance. And remember, by that stage, in October 2021, most of the country was back to normal. And I was asked to review that changes to that guidance. And I totted it up. In total, I made 62 comments on what I thought was inappropriate and wrong with that guidance. 10 of those were where I thought it was discriminatory, and I pointed out to them where it had the potential to breach Equality Act, Human Rights Act. There were 4 instances in that guidance where there were blanket approaches still being taken. There were 6 instances where the guidance was actually taking us backwards rather than forwards. And in 15 places, the guidance was contradictory to either something else in that same version of the guidance or something else that they, in different versions of guidance. And my overarching comment at that stage was that a massive overhaul to that guidance was needed, given where we were with the rest of society and other restrictions being lifted, the country almost being back to normal. And I said it needed to start from the place, from an approach of focusing on rights and focusing on well-being, with infection prevention control measures obviously added in where they were necessary and proportionate to identified risks. And that was because we needed a shift in approach, and we needed to delineate that shift in approach to end what we were seeing of closed cultures that had kind of been developed and embedded during the pandemic. There were some improvements that were made as a result of that, a kind of clearer focus on autonomy and rights, but it was a constant battle. And though in the next version of the guidance, I think it was November, the very next month, we were asked to look at the guidance again. And there was a positive piece in the guidance that had been taken out, even though I'd plead with them to keep it in, around if people have capacity to make decisions to go out and leave their care home, they couldn't be stopped from doing that without a kind of legal framework to do that. And so there was a sort of persistent request to the Department of Health and Social Care to meet their own legal obligations under the Equality Act, under the Human Rights Act.
And can I just ask, in the event of a future pandemic, how do you think it is that we can ensure that the voices of the sector are heard? So is it through working groups? Is that the way to do it? Are there any other ideas your organisation has?
Well, I think what was useful about the working group was that it gave the government and it gave the policymakers a route through to the sector to hear what was happening on the ground and to hear the reality of what it's like to be at the tail end of the decisions that they were making. So I think those kinds of routes definitely are good, and that's why I wanted it to continue, at least until the guidance had fallen away and there were no longer restrictions on people relying on care services, as long as the group has proper representation on it. I mean, we weren't invited till the summer of 2021, and we were only invited as a result of John's campaign insisting that we be engaged. There was no representation from people who were relying on services directly or their families. It all came through organisations. And I think, so the structure and the makeup of the group needs to be correct for that for it to do its job properly, but also how that group operates and at what points it's brought in to engage, so that it's not too late to have any kind of impact on what the guidance said, but also the expert voices on that group are listened to and respected, and action is taken as a result. If I could just give an example of that.
I'm just conscious I have a lot of topics that I wish to explore with you, but I do have another question if I can.
Just before you ask it, I know you've got a lot to tell me, and I do understand, but we're okay for time today, so if I could ask you to speak more slowly.
Sorry.
It's all right.
Sorry to
it's right, you're not the first, and I've no doubt you won't be the last witness.
In respect of the evidence that group was receiving, one of the things you note is that a member of SAGE in that group said that there was an evidential black hole around the impact of isolation, but that the harm was overwhelming. What more could have been done to collect evidence to provide to that group by the government, in your view?
Yeah, so that was as a result of us consistently asking to see that evidence. So we had actually submitted a rewrite of the guidance to the stakeholder group, which started from a position of these are the rights, these are the lawful restrictions that can be put on their rights, these are the infection prevention control measures that should be in place as a precaution. That was supported by several members of the stakeholder group, including the organisations you've heard from already, National Care Forum, National Care Association, as well as Care England and ARC from the provider side, and the Alzheimer's Society as well. That was rejected within 40 minutes of me submitting it to the department, which is not long enough to even talk about it with your civil servant, your civil servant colleagues, let alone present it to a minister as a approach that was supported by so many of those voices in the stakeholder group. And that's what I mean about those voices. If you're going to collect those people around the table and hear from them, you have to respect the views and the suggestions that they make to you. And as a result of that, the response we got back said that the clinical evidence, the clinical advice wouldn't support that kind of light touch approach, is what we were told it was, even though it was based on legal duties that were in place at the time. And as a result of that, we then requested the evidence. We said, well, are you actually collecting evidence of the harm being caused by isolation? We were constantly told that they were taking advice on the clinical evidence around the harm of COVID, but we were constantly asking, well, are you balancing that against the harm of the restrictions that are being put in place? And that's what led to the SAGE colleague coming to one of those meetings and admitting that. And I think there wasn't enough being done to hear those types of stories. Whether there was data, whether it was kind of statistical hard data or not, there was certainly story after story that we were hearing, that our colleagues were hearing, other organisations were hearing, and we were getting them out there. We were putting them in the media. We were writing to the government, to the regulator, telling them these stories and these examples, and they weren't heard. So there was plenty of opportunity for them to stop and take stock of the impact of those restrictions.
And can I just move on, please, to a slightly different topic? In your statement, you say there were very few other sources of support as key agencies and professionals who had legal duties to protect those in receipt of care stepped back. And you discussed the CQC, who paused routine inspections. What were the concerns about the lack of routine inspections during the pandemic? We had concerns about the CQC's approach to its regulatory regime before the pandemic, I should say that. But what we saw during the pandemic was the CQC abdicating its responsibilities, pausing those regular inspections, which actually never properly returned, and that led to the Secretary of State recently calling them not fit for purpose. But that vital role of the regulator in maintaining minimum standards was so important during a time of crisis. Well, that's when the people using and relying on those care and support services really needed them the most. And it left people at risk. People who were at risk of abuse were abandoned when the services and the systems designed to protect them backed away, CQC as well as safeguarding teams. People at risk of neglect when we saw services stretched. Staffing issues were a problem before the pandemic. Got much worse during the pandemic itself when people were themselves going off sick, and at the same time care workers were being asked to fill the gaps left by other services when health professionals, etc., stayed away. But also the vital role of the regulator in monitoring those sort of everyday indignities that wouldn't be serious as abuse or neglect, but the sort of what it's like to be on the tail end of a poor culture that has been a poor culture over many years. And you explain, in fact, that your organisation wrote to the CQC a number of times to express your disappointment with their role during the pandemic. And the CQC has provided a supplemental statement to the inquiry. And at paragraph 14, and just for reference, it's INQ 30587795, but I don't need to have it on screen, thank you. It says they sent a number of letters in response, and they say that those those letters clarified how the CQC was continuing to monitor and inspect, how we were sharing information and data within the sector, and the support that we were providing. And in our 20th of May 2021 letter, we also provided clarity on our role in relation to visiting in care homes. Did their responses allay your concerns, or did you continue to have concerns throughout the pandemic?
They didn't allay our concerns at all. I'm afraid their responses were dismissive. We would send them evidence of harm alongside those letters, which, as I said, seemed to make no difference. They were defensive. They read as almost CQC trying to justify their actions, trying to justify their position. And there was a massive focus on what they couldn't do, as opposed to what they could do. And we had actually set out in our letters requests for them to be proactive and to actually take some action to try and represent the voice of the sector, but also to ensure that the sector was meeting its legal obligations. And that's what CQC is there to do. Those minimum standards are set down in law, in their regulations. And I think the response was also quite submissive. I think there was the public health voice seemed to dominate. And I think I've got an example in terms of at a time, I said CQC, during a crisis, those minimum standards become so important, because it was also at a time when family and friends who were there to support people relying on care services couldn't be there to carry out their normal role of the eyes and the ears on the ground to spot concerns. And the guidance that CQC issued alongside the government guidance, we were really worried that was encouraging breaches of its own regulations as well as breaches of legal rights. So they had in their guidance in May 2022, so again, countries back to normal, and guidance at the time, government guidance at the time said that there was, so let me start again. So there was the government guidance around isolation after hospital appointments in May 2022. There was no reference in CQC's guidance to person-centred care. There was no reference to the need for individual assessments. And what was most concerning about that to us, that it was in a section of CQC's guidance which said was best practice, good practice. And that was inconsistent with government guidance at the time, which had been updated weeks before that, which obviously creates lots of confusion for people. So that's what we wrote to CQC about. One of our letters was specifically about that guidance. And they did amend it, and they said in their letter they were going to amend it. But there were still concerns around how it was amended. It was still encouraging breaches of those regulations in sections that were called good practice. And we actually wrote back to the CQC privately to offer to help them to rewrite the guidance, but that wasn't taken up.
I'm sorry to interrupt, can I just go back to points that you may have heard from other witnesses? I do understand the concerns about suspension of inspections, of course I do. Obviously, as you say, you haven't got the usual eyes and ears because you haven't got other visitors, you haven't got health professionals, you haven't got family carers and the like. But as far as the CQC were concerned, it was a balance of risk, wasn't it? It was a balance of risk, obviously, to their inspectors going into the care homes, but then a balance of risk, the risk of infection to residents and to staff in care homes. I appreciate that you think they weighed up that risk wrongly, but presumably you accept that they were right to balance the risk.
Absolutely, balance the risk. That's what everyone was trying to do. I think what they did was they put too much focus on the risk of that the pandemic posed, whilst at the same time not putting enough focus on the risk that those restrictions and the measures that were taken in response to the pandemic posed. They didn't seem to factor very much at all in the approach. And I think what that led to is a sort of, we ended up in a kind of upside down world where non-statutory guidance was given precedent over legal rights. And I think CQC's response shows that the government's approach, and it is, to the way it managed the pandemic, shows that there wasn't enough focus on the harms that were being caused by the restrictions put in place. And of course, you reduce footfall. Of course, you do that. And of course, you use infection prevention control measures to protect people and take precautions. But I think from our perspective, there were certain bottom lines that should never have been crossed. And I think health practitioners backing away, safeguarding teams backing away, the pause on routine inspections, all of that left people at risk. And I think what I'm saying is there hasn't been as much focus as there should have been on that risk and on the harm that caused. And I think...
Can I just pursue while you ponder what you were going to finish your answer with? Yes, by not having the safeguarding teams and the CQC routine inspections, it put people at risk. But again, that is a question of the balance of risk. And as I understand it, and don't think this is necessarily my view, I'm just putting forward the other side of the argument. As I understand it, at the time when inspections were suspended, the focus was then on stopping this virus running through the entire country, causing goodness knows how many deaths and how much suffering. And of course, nobody knew then how long it was going to last. And so if you're then balancing the risk of neglect or abuse against the risk of a fatal virus getting into a care home where there are many vulnerable residents, isn't that a fair balancing of the risk at that time? I appreciate you may say it went on too long, do understand all of that, but when the decision was actually taken?
And you can see in the early stage of the pandemic and the fear of what this pandemic could do, and the people who were most vulnerable in terms of older people, disabled people. So I don't envy them at all making these difficult decisions. And I have a lot of empathy for the decision makers who were having to weigh up that balance. And you're right, we didn't know how long it was going to go on. We didn't know, but we could look to other countries to see what was happening. And we had seen what was happening in Europe and other parts of the world. And I think there wasn't enough of a kind of learning of lessons from what was happening around the world, but also a learning of lessons from what was happening here around how long that was going on for. And so, yes, CQC paused routine inspections at the beginning, thinking they were doing the right thing in terms of not spreading the virus, not taking more risk into those kinds of settings. But the longer that went on, the more that other risk of the isolation of people in those care settings became far too great. And even at that stage, there didn't seem to be a change in approach. And even CQC saying that they were they were focusing on risk. They were trying to balance those risks, but they were also focusing on care settings and people most at risk. Well, how were they doing that? How were those judgments being made when, at a time when people in care settings were unable to be with their vital support networks that they're used to, who, for people who might have communication difficulties, might not ever be able to speak out about concerns that they had about their care, particularly around abuse or neglect. When all those other professionals are not there to be the eyes and the ears, when families and friends are not there to be the eyes and the ears, you're only relying on whistleblowers and on people themselves speaking out about their poor care. And how the barriers that people had around that, if they even had the ability to speak out about poor care. Did they have a phone in their room? Could they call CQC directly? Could they, how were they ever going to speak out about that themselves? And having the confidence to do that when the person that you're complaining about is the person who is providing you with very intimate personal care. And the fear that people have, this is a consistent theme on our advice line, before the pandemic, during the pandemic, and today, is the fear that people have of raising concerns and issues about their own care or on behalf of a loved one, because of a fear of what will happen, for repercussions, the fear that the care will get worse, or that they will face restrictions around visiting. People can be, often we hear people being evicted for raising too many concerns about their care.
I think we've moved beyond my question now. I'll hand back to Ms. Paisley.
Sorry.
Thank you, my lady. Can I change topic then, please, to essential caregivers? What is the significance of the role of an essential caregiver? And what are the risks for individuals in receipt of care if they don't have that support?
So can I focus first on the role of an essential caregiver? I think the use of the word visiting misses the many roles that a person plays when providing support to somebody in a care setting. It's not only about company and companionship and love, but the many roles that a relative or friend might take in terms of a carer. They might themselves get involved in providing that care. As we've said, they're the voice, they're the eyes, the ears, the advocate for that person, raising concerns on their behalf. They might be the only person that person would tell that if they were in pain or if they were at risk of poor care. They are the memory of that person. They provide a link back to, previous homes and relationships. They might be the translator for that person. They can pick up cues and signs, particularly if somebody is no longer able to verbalise. They can pick up when someone might be in pain or when there might be something that they're trying to communicate. And so that essential support can be practical, but it's also emotional. And I think what we've been calling for in terms of the right to a care supporter is not about visiting. It's about the kind of vital support that people have from the person who knows them best and the person that they have chosen to be their eyes and their ears and their voice when they need it. And so the kinds of roles that people were playing during the pandemic and before and today, support with eating, for example. So there was someone we supported, a woman called Rosemary, who her husband used to go into a care home to support her to eat 6 hours a day. When he was refused access, even though he bought his own PPE to try and follow the IPC measures, Rosemary refused to eat and drink, and he told us that she starved herself to death. As I say, there are many roles that people play, supporting people to live well with dementia, for example. So one of the people we supported, Helen, would go in and when she was allowed in to see her mum and provide that stimulation. She had taught herself how to support somebody to live with dementia. And so she would play music and songs that would remind her mum of previous times and hold her hands, albeit with gloves on, just to provide that kind of physical contact that can be so important for people with dementia.
And if I can just, I think you've actually, in fact, answered my second question, which was the risks. But I think you've covered that in the evidence that you've given. In the event of a future pandemic, then, does your organisation believe essential caregivers should be able to continue attending a care home or a care setting under all circumstances?
So I think, of course, in a future pandemic, you reduce the footfall, and we're not saying open door policy. And like I say, what we're calling for is not about visiting, it's about vital support. So what we're saying is that people should be able to nominate a person, or potentially, if there are different support they get from different people, multiple people who they should never be isolated from, because what that person is providing them is so vital for their care and support that they should be seen as part of the care team. They should be their partners in care. And they should be treated in the same way as a care worker would, with all of the same precautions around testing and PPE, etc.
And did any nation in the UK that you're aware of get this right, or is any nation taking steps that you think are adequate in respect of essential care?
Well, we did have essential caregivers written into the guidance eventually, and I know that happened across in Northern Ireland as well, and across other parts of the UK. What we're saying is that guidance was not enough. We saw so many people who were refused an essential caregiver, even when it was in the guidance. In fact, one woman, Anne Ablett, she asked for to be the essential care supporter for her mum when that was allowed in the guidance. She was refused, and then when she came back to them and said, this is what's in the guidance, she tried to push that. Her mum was evicted from her care setting, and actually her mum passed away before that eviction notice could take place. But what we saw, huge variety and variation in the response to that being in the guidance. Many care settings welcomed essential caregivers in, recognising that they played that vital role. And in fact, some care settings had never stopped that people performing that role from visiting, because they recognised the mental health implications and the kind of the physical health implications of cutting people off from that essential support. But for other settings, we saw huge problems with the essential caregiver role only being in guidance. And so that's why we're calling for a legal change, for it to be a legal right. And we, as a response to our campaigning, the government, previous government, brought in a new fundamental standard on visiting. So Regulation 9A is now a new fundamental standard.
Can I ask you then a question about Regulation 9A, please? And the inquiry heard evidence from Michelle Dyson about that. Is that a positive step? And do you have any does your organisation have any comments or concerns?
It's very welcome, and it should always have been a fundamental standard. Visiting and contact and companionship with the people that you want to maintain relationships with in health and care settings is absolutely vital, and it should always have been a fundamental standard. But what we see is huge problems with that on the way that's being implemented on the ground now. So Regulation 9A has been enforced for a year. It came in April last year, and from what we hear through our advice services is that that is not working. So we are supporting people who are still facing restrictions on visiting, and they're trying to use Regulation 9A to challenge those restrictions and being told by the care provider that they don't need to follow that. So if it's not working now, it's what's going to happen if there is a future pandemic and if there is a sort of crisis point. I fear the same will happen as with the rest of the fundamental standards that just fell by the wayside when the pandemic hit. And so the issues we have around Regulation 9A is that it's not guaranteed. It relies on the CQC monitoring it. CQC can't investigate individual complaints. And the CQC's own evidence to this inquiry said that it was too difficult for them to monitor breaches of visiting guidance. So we need a shift. We need a culture shift, and we need to shift the power back to the person and allow them to choose for themselves to nominate who that care supporter is. And that will respect their autonomy and their choices around whether they want one or not, and if so, who it is. And then it will shift the power back to the person, as opposed to it being, as it is at the moment in the regulations, a duty on providers that is monitored by CQC. This will be a legal right that sits with the person.
Can I change topic again, please? And I appreciate the significance of giving a voice to those that you represent, but if I could invite you not to use full names, if you could just use first names, if at all possible, please. Now, Care Rights UK undertook a survey on healthcare experiences of those living in care homes during the pandemic. You explained that this was undertaken in May 2023, but it was carried out with the aim of collecting information on the healthcare experiences of people in settings during the COVID-19 pandemic, with the benefit of hindsight. And you say that these findings illustrate what you were hearing day in, day out through your advice line. Now, your statement deals with the requirements at points in the pandemic for mandatory isolation following visits to healthcare facilities outside of the care home upon a resident's return. And you say this had a chilling impact upon people's ability to access healthcare. And one example is a response to the survey which said mum delayed going for X-ray until after Christmas. She would have been isolated over Christmas 2021 for 14 days. She was in considerable pain and her mobility was affected. And so did your organisation hear evidence that people were effectively having to choose between being isolated on one hand or living in pain on the other?
Yes, we did. And that led to impossible decisions for people about whether they would seek health support that they clearly needed. There's another example of a woman in a care setting begging their daughter not to remind care staff about appointments for cancer because they were so anxious about isolation that would result from that. And I think there should never have been blanket rules. Blanket rules, by their very nature, are not human rights compliant. They don't take into account individual needs and the needs for those individual assessments that are so important. All of this should have been done on an individual basis with an assessment of risk, both the risk of COVID as well as the risk of harm from isolation. And precautions like testing, PPE, etc., can be used in both the health setting where they're getting their health needs met and in the care setting when they return to manage those risks.
And so in the view of your organisation, it may be that isolation might be appropriate where there are risks, but there should be steps taken such as testing and PPE to try and mitigate those risks and reduce the length of isolation. Would that be a fair summary?
Yes, although I do have some concerns about the blanket use of isolation, and I think that's we heard so much harm that was being caused by those isolation measures, not only after visits out, including health appointments, but also when care homes had outbreaks and went into lockdown, homes went into isolation, visiting was restricted again. And those isolation periods caused untold suffering to people around. So we have people who said that they were longing for some wallpaper to look at, so they didn't have to look at white walls. People told us, I'm barely existing. There were people who were self-harming, withdrawing and hitting themselves in frustration, biting their arm because they couldn't verbalise their distress. People who were strapped in their chair for 14 days. We supported somebody whose food was left on trays outside their room, so they didn't eat, and their family had to move him from that care home.
And so this is the significance of assessing in each case then, in the view of your organisation, undertaking a risk assessment tailored to the individual.
Absolutely.
Sorry, just pausing there. Again, I'm not saying this is my view, I just want to put to you something just in case I have to consider all arguments. If you're the hospital giving somebody an appointment and you've got all sorts of measures in place to try and stop the transmission of this deadly virus, how do you carry out an individual risk assessment for the individual in a care home when it comes to working out how or when they should isolate or for how long? I just don't understand how a system that was creaking, as we know, to cope with this deadly virus, how the individual hospital is meant to carry out the risk assessment and not insist on having a 14-day isolation period. And it wasn't, of course, just people in care homes and the like, in receipt of care, who were subject to breaches of their rights. We all were, because we were all told we had to do things that normally our rights would be protected. So I'm not finding how it would work, that's all.
Yeah, so I think that's a really good example of where a health service and a care service have to work together. it may be impossible for a health practitioner to assess that person over a screen or over the phone, to assess the risk for the hospital themselves. And that's where the relationship with the care workers comes in terms of carrying out that risk assessment. They know the person, they're providing that support to that person every day. Involving that person in that risk assessment is absolutely vital. Hearing their voice, hearing what impact that's going to have on them in terms of the impact on their health of not receiving that support, but also the impact if they are asked to isolate for 14 days afterwards. Involving the person's family or their chosen representatives in that conversation too, to help make a decision about what is best for that person, as at the same time trying to protect the health workers, the care workers who are going to be supporting that person, but the other patients and the other people living in that care setting as well. And I think we didn't see any of that. We didn't see people being involved in those risk assessments, and we didn't see the voice of people supporting them, their family and friends who, like I say, for people who are non-verbal, for people who have difficulty communicating, those people can pick up on those signs and those little cues that people give to assist health and care workers with that. And I think too often people, relatives and friends, are seen as a part of the problem rather than being part of the solution. And
yes, thank you. So I'm going to hand back to Ms Paisley.
Sorry, thank you. Can I please ask some more questions about the survey and some of the responses that you received? And so can I have on screen INQ 302734449, please, at page 13? And this is in respect of end of life. And so the experiences of those in receipt of care and their loved ones' experiences. And just to read some of these responses: great distress to us both, still upset by the memories of those difficult last months of her life, not even allowed an end-of-life visit. The manager told me she's close to the end of her life, but not quite there yet. On a video call, my mum pleaded with me to visit. Video calls were very difficult as she couldn't see or hear properly. Another one reads, an unhappy and difficult death, anguish for family, lasting trauma. Dad died without good end-of-life support. I experienced PTSD. Devastating impacts, no support to me as the person having to face such horrific circumstances alone, and no support for my mum stuck in a room dying alone. The carers don't have time for emotional support, and especially when they were dealing with 22 other deaths in the rooms around them. At paragraph 124 of your statement, you explain, even when guidance did allow visiting, some care providers enforced stricter restrictions than required by the relevant guidance at the time, including because terms such as end of life, which allowed for exceptional visiting, were not clearly defined. What is the importance of properly defining terms such as end of life? And do you think that that had an impact upon some of the responses that we've seen here?
Yes, I think for me, this is one of the most inhumane aspects of our response to the pandemic. The lack of palliative and end-of-life care led to unnecessary suffering and trauma for loved ones who were witnessing that suffering. People dying alone and being denied a dignified death because of isolation from loved ones until it was too late. And the cruelty of allowing end-of-life visits, and then when they happen and the person rallies because their loved ones are there, those visits being withdrawn again. And that terrible, the emotional roller coaster you go through as the person who is dying, but also the person who is there to say goodbye. So that happened to someone we were supporting, Leslie, who had been in care for 7 years, and her husband, John, supported her to eat and drink, and he was allowed end-of-life visits, but then they were withdrawn when Leslie started to eat and drink again, when she responded positively to him being there. And John described that as unbearable. And for the people who are left behind, the bereaved families, the anger, the guilt, that the trauma that some people will never recover from. And I think the inconsistency we heard around end of life, whether it meant final days, final weeks, sometimes it was final hours when the person was already unconscious. And it wasn't until December 2020 that the guidance was amended to say that end of life should mean the last year. But the guidance was inadequate, it was not clear, and it came too late when poor practice had already been embedded. And I think there was a lot of fear from providers about doing the wrong thing. And I think when we heard the Prime Minister blaming care homes for the high death rates in care, saying that too many care homes didn't really follow the procedures in July 2020, I think that just embedded the fear. And I think looking to the future, we need proper training on end-of-life care for care workers. We need to ensure access to palliative care for people in residential care. We need to embed that last year of life as standard practice. And we need to ensure that people's choices and autonomy around how they want to end their lives are respected, which includes recognising the importance of loved ones in supporting a dignified death.
Can I just ask 2 follow-up questions on what you've said, please? The first is in respect of healthcare workers visiting into the home. So we've touched upon visits out and the isolation that followed that. But in the view of your organisation, should there ever be restrictions on healthcare workers visiting inside residential settings?
I think there are some people who are so fundamental to providing basic good care that they should never be kept away. And I think palliative care workers, health professionals, safeguarding teams, regulation inspectors, all of those people are so important for protecting people who are in the most vulnerable of situations in a care home, in a care setting, where the power imbalance is so skewed and people can feel completely powerless in those kinds of situations. And when family and friends are being kept away, that those professionals become even more important. And for people who have no one, there are many people in care settings who have no family and friends. Those professionals become their eyes and their ears and their advocates. And they're too important to keep away. There should never be blanket rules on that. And I think it has to be a managed response. We have to use the infection prevention control precautions that are there to protect those workers whilst carrying out that vital role.
So the significance of PPE for the sector then, this underscores the importance of that. And then my second question was, in terms of how the guidance communicated the phrase end of life, and you also raise exceptional circumstances, which is another phrase, do you think that there should be a very clear prescriptive definition of what is meant by that? Or should there be examples of what may constitute those definitions so that there can be a risk assessment? Do you have any views on how that could have worked more appropriately?
Well, I think it's going to be different for every person. And I think we have to, and this is why blanket rules never work, we have to take into account the person and their individual circumstances, their individual needs, but also their choices and what they want. And again, family and friends can be really important in supporting that person to make those decisions. But also if the person has already lost consciousness or doesn't have capacity around making those decisions for themselves, family and friends become really important in making sure that those previous wishes have been respected. And I think embedding last year of life, we have to take advantage of being outside of a crisis, what we can learn from this pandemic, and embed that good practice now before we hit another crisis point at some point in the future, which may not be another pandemic. It could be anything around the corner in terms of an outbreak of flu or whatever it is. Embed that good practice now and talk to people, engage with people, get that guidance now as good as it can be, whether that includes things like examples. I mean, we've got some terrible examples from the pandemic to share with practitioners around what bad looks like, but also what good looks like. We have to learn those lessons now so that we're ready for the next
And
time we
stakeholder
need them.
engagement is crucial to
Absolutely.
that. I have one final topic, please, before I move on to some final reflections, which is DNA CPR decisions, please. And if we can have back on screen, please, the survey at INQ 302733449, this time at page 15. And again, if I may, I'm going to read some of the quotes here. It was explained to me that the NHS was too busy to cope during the pandemic, so decisions were made to not actively keep someone alive if their age and condition meant the outcome would not be in the NHS's interests. Another one states, coerced to comply. Another one states, given my mother's emaciated state, resuscitation would have broken her ribs. We agreed it would not be in her best interest to attempt it. However, what later became clear was that DNRs were being used as a shorthand for do not treat. This was my mother's experience. The hospital put her on the palliative pathway within 2 days of her hospitalisation against our wishes. I had to go through the COP to get my mother discharged home, where she lived for another 14 months. And you explain in your statement at paragraph 235 that respecting individual autonomy, facilitating open and honest communication, and involving designated representatives in the decision-making process are essential to prevent inappropriate or coerced implementation of DNA CPR decisions. How important are those principles going forwards for the future?
Yeah, absolutely. I think the practice that we saw, the poor practice that we saw around do not attempt resuscitation, again, completely unacceptable response and should never have been allowed to happen. It's an example of how existing laws fell by the wayside in response to the pandemic.
And can I just ask, were there a handful of examples that your organisations were receiving, or was this more widespread than just one or two examples?
Luckily for us, we weren't overwhelmed with examples directly to our advice service, but we did get them. And when people came through with them, what the overwhelming sense of that was the fear that if this decision has been made about my relative, without my relative knowing, without me knowing, what else is going on that we don't know about when something as critical as this is being made without our consultation. And it just added to that feeling of complete powerlessness that relatives and friends were already feeling by being, shut away and not involved not able to carry out their caring role and not involved in those conversations as they should be. When we did the survey, obviously we saw that it was much more widespread, and other organisations have also attested to how widespread it was. And it's hugely concerning that something so important as that was, which has legal rights and duties attached to it, that just fell away. And we saw poor practice coming back in that made people feel that their lives were worth less. It devalued the lives of older people, disabled people, and made them feel that they were dispensable.
And then just my final question, please, which is to ask you to reflect upon the evidence that you've given. And aside from anything that we've already been through, is there a particular lesson or recommendation you would ask that this inquiry considers, please?
Yes. So I would have talked about our right to a care supporter, because that's absolutely fundamental change that came out of the pandemic, but we know has been a problem before the pandemic as well. But we've already touched on that.
We've touched on that.
So I will say, I think human rights provides a vital safety net, which is more important in times of crisis. It is, our sort of understanding of human rights and our human rights laws today came from crisis. They were written after World War II, and they provide those basic minimums and that safety net as standards below which no one should fall. And they also provide a very practical tool as a framework to help us to make decisions. And our response to the pandemic should have started from the point of human rights and those minimum standards. And we should have used the framework that human rights gave us. And if we had done that, many of the problems that we saw coming out of the pandemic could have been avoided in terms of blanket policies and the degrading treatment that we've talked about. And my recommendation, what I want to see for the future, is for human rights laws being used as the bedrock for a response in a future pandemic, and using that framework and those basic standards so that no one ever falls below that. And that means mandatory training for health and care staff, not just on how the laws work, but everyday practice. I used to provide that training. I was at the British Institute of Human Rights, training care workers, social workers, health workers on how to do that. And when you train them on the law, but also how it applies to their everyday, you can see those light bulb moments happening where they see that this is actually a really practical tool that can help them make the really difficult decisions they have to make every day, but it gives them a legal hook for that and is values-based and picks upon many of the reasons that they went into those jobs in the first place, because they want to treat people with dignity and respect and ensure that no one's ever left in degrading conditions, etc. And so that's my plea for that training to be mandatory.
Thank you. That's all my questions.
That completes our questions for you. Thank you very much indeed, Ms Wildbore. You're obviously a very passionate advocate for your cause, and a very good one. It must be extraordinarily distressing for you and your team, some of the calls you had to receive. So thank you to you and to your team for all the work that you did to try and support people at a really desperate time.
Thank you.
And thank you for your help with the inquiry. Very well, I shall return at 1:45.